හරි කාර්තියන බැරි වුණොත් මම කතා කරන්න. Pavita, I'm going to start, right? If there's any problem in hearing, call me immediately.
Okay, madam.
Pavita නේද ඔය?
Hello. Salman, madam, the badge rep.
Okay.
I'm the badge rep, madam.
Right, now today it's a very important lecture. It's there. It's something that should be there for the entire until you finish the medical career, medical school, and even after that. Right. So this is one of the most important lectures. Listen carefully. I hope it will get recorded, and I will upload if it gets recorded. But anyway, listen carefully. You have the note also. Now. We have obstetrics and gynecology has two subjects, obstetrics and gynecology. First, we'll do the obstetric history and examination, and this will be followed by gynecological history and examination. Only thing we can't do the practical part now, but once Corona is over, I'll make some arrangements to teach you all the practical part. So this is for your entire life. So listen carefully. You can ask me any questions either on the Zoom or on my phone or on the email. So listen very carefully. Now, clinical history in any subject, not only obstetric, should first of all be diagnostic. Why are we taking a history? Not because we have a mouth, not because we like to talk to the patient. The only reason to take a history is to make a diagnosis. So if your history doesn't have a diagnosis, it won't carry you any marks. And as early, and remember, though history and mystery are rhyming words, history should not be a mystery. Diagnosis should be there as early as possible in the history. Now, in most cases, especially in obstetrics and gynecology, and I think in any clinical field nowadays, the patients know the diagnosis. So she will tell you that I have come for Caesar because I have a breech presentation. Or she will say, I have diabetes, so I came for a blood sugar series. Or she will say, she will specifically even tell you that I have fibroid, I came for hysterectomy. Or because they specific, most of them, 99% of them know the diagnosis. Why? Because they go for private consultations, they are educated nowadays, and there are so many investigations that they do. So by the time they come to the hospital, they know the diagnosis and they know even why they have come for. I think I'm very happy that I'm doing it fairly early in your clinical career so that you can get rid of all these myths and beliefs you have regarding any history. So you all have the idea, because you all are beginners, you have the idea that history should be like a mystery story, and at the end, that you should not unravel the most important clue even at the end. That leave it for the discussion, and then the consultant will think that, you are a very good student, you have made a diagnosis on your own. No, it won't happen like that, because we definitely know that the patient knows the diagnosis. And we always tell the patient, tell everything you know to the candidate. We never tell the patient to hide everything from the candidate. So these are myths and beliefs you all have. So get rid of those. Remember, patient knows everything, most of the patients, and we also know that the patient knows everything. And we have not told the patient not to really reveal anything to the student. So history should be diagnostic. You should be able to find the diagnosis once you come to the final year within the first few sentences. So any history in any clinical subject should be diagnostic. And remember, you get marks only for a diagnostic history. History should be scientific. For God's sake, you can talk to the patient who will say, I have come for a DNC. Patient will say, I came for a womb wash. But you can't use those words in your presentation. You have to be very, very scientific in your presentation. You can talk to the patient in any language, You are presenting the history in English, and it has to be scientific English and not the English that is used by normal people. It should be scientific medical history. So you can only use scientific words. You have to get rid of all the non-scientific parts of the history. So these are the myths and beliefs you have, that you have to present the history in the words of the patient. Have you ever heard any doctor talking in those words? You listen to what the house officers are telling. Now you all have done about 1 year of clinicals now. Have you ever heard them talking about this, talking in these unscientific words? No. So history should be very scientific, and only the scientific details should be included in the history. You should not include any unscientific details in the history. History should be presented in a chronological order of events, and it should have beginning, middle, and an ending. And it should be short and to the point. Now, if it's any history, it should start at the beginning of the illness and the history ends today. History doesn't end on the day the patient gets admitted to the hospital, because sometimes there may be a large gap between the patient getting admitted to the hospital and the day that you are presenting the history. So remember, history ends only this morning. History doesn't even end yesterday, because you have to tell everything. The most important part of the history may be what has happened in the hospital. So you can't just stop and say, our patient was admitted on such and such a date. You have to tell what happened, but that may be the most diagnostic part, what was done in the hospital. So it's very important to talk to that the history ends today. And history should start at the beginning of the illness, talk about the diagnosis of the illness, talk how the illness got aggravated up to this moment, and not only that, all the treatment that was done so far and the investigations that have been done so far should be included in the history. So beginning will be the beginning of the illness, middle will be how the illness aggravated and the treatment and the investigations that were done and the treatment that was taken and the response. It ends only today. And when it comes to obstetric history, it can start preconceptionally, and then with the first trimester comes first, second trimester comes next, third trimester comes at the end, and it ended with, and it end today. So it should always be presented in the chronological order of events. It should be short and to the point. I'll explain what is meant by that as we go on. It should be short because you have to save time. You have only 20 minutes to present the history and do the examination and discuss. Because you get only 10 marks of the history, 10 for the examination, 20 for the discussion. So if you don't leave time for the discussion, then you won't be able to score a distinction mark. You can barely manage to pass, but that should not be the point. You should be able to, all your aim should be, every one of us is the first time that I'm encountering you. Every one of you all should aim to top the batch. And every one of you all should aim to get a first class. If you aim high, you'll reach something. And yes, history should be short and to the point. You won't get any marks on non-diagnostic parts of the history. I'll explain it as we go on. So the only purpose will go down with your note. The only purpose of taking a history, as I told you, is to diagnose a disease condition. Therefore, it is important to arrive at a tentative diagnosis or at least a differential diagnosis before the end of the history. This should be mentioned as early as possible in the history. I'm going through your document and I'll explain anything that is left to explain. Sometimes the woman may be aware of the diagnosis as a disease condition may have been diagnosed at the antenatal clinic or whatever clinic that she is attending. Or maybe it was diagnosed by a general practitioner. Actually, I'm telling, this is, though we say it's obstetric history taking an examination, this will be important for you in all the clinical disciplines. That's really broad basing this history. So not sometimes, almost always, someone will be aware of the diagnosis as it may have been diagnosed at the clinic or at the GP. In such a case, diagnosis should be maintained very early in the history. Non-scientific details and words mentioned by the patient should be converted to scientific medical words when the history is presented. History should be short. Only the details required for diagnosis of the disease condition should be presented. The student should realize the details required to arrive at a diagnosis early in the process of taking a history. Now, you all should train yourself to do that. I will talk about that at the end. But you all have to, how can you train yourself to take a good history? By taking as many histories as possible. So you should train yourself to realize the details required to arrive at a diagnosis early in the process of the history. I'll explain all this as we go on. The history should have beginning, middle, and an ending, and should be presented in the chronological order of events. History should commence at the beginning of the illness and end on the day the history is taken by the student. An obstetric history should commence at the last regular menstrual period or at the preconception visit. Events of the first, second, and third trimesters, together with the antenatal clinic details, should be presented in the appropriate order. Now, the time at this other important point, very important point. Time allocated for history and examination is 20 minutes. Students should not spend time. It's so disadvantageous to spend time trying to elicit ආච්චිගේ මුත්තගේ සීයක businesses. So you should not elicit details which are not helpful in the diagnosis and the management. You should not be in a particular frame. I'm so happy I'm doing it now, I'm telling you, so that I can change your frame, because you all are just constricted or restricted into a frame that someone has given you, and you try to fill all the details of that frame, which is definitely not necessary. Students should, and also students should commence the examination while taking the history. I will explain that later. Marks will be, now this is the most important crux of the matter. Marks will be awarded for a scientific short history without unwanted details. ආච්චිගේ මුත්තගේ සීයාගේ details වලට ලකුණු හම්බ වෙන්නේ නැහැ. Which is help. So marks will be awarded for a scientific short history without unwanted details. That's the most important thing, which is helpful to arrive at a diagnosis, or at least a differential diagnosis. It would be a definite disadvantage to include unnecessary details and repeatedly tell. Right, so that is the basics of history taking. Now we'll go into the obstetric history. But remember this, even what I'm telling now also is important. Take it into your head, because it will be of great value for you in the other disciplines as well. So what is the basic obstetric history? Now what I'm explaining is the basic obstetric history. Modifications which should be made in different conditions will be given. Actually, this is the first chapter of my book. I strongly advise you all to use that clinical guideline in obstetrics and gynecology. So this is the first chapter of the book. So I'll tell you the modifications as we go on. And obstetric history should have the following component, any history for that matter. There should be introduction. Always there has to be an introduction. Then there has to be a reason for admission or presenting complaint. Now in all the other disciplines, there's a presenting complaint. But in obstetrics, there may be no presenting complaint. There may only be a reason for admission. I'll explain later. Dating of the pregnancy and the menstrual history. For present obstetric history, remember in obstetric history, the most crucial history is the present obstetric history. Now, just forget about the history of the presenting complaint for the moment, right? I will explain that as we go on. Past obstetric history, past medical, surgical, and drug history, social history, and dietitian. Now, when you look at this, the framework is there. This is the framework that you have been taught. I don't know when you were taught this, but anyway, this framework must be there very strongly in the front of your cerebrum. It must be there right in front of you, this framework. And I'm sure you all are sticking to this framework in the real way, right? I want to break this also, because sticking to the framework won't get you much marks. So this is your framework. You'll see how it can be altered. Although the above order of presentation is usually accepted, these components can be presented in the order of importance of the diagnosis and management. Not only presented in the order of importance, it should be emphasized also in the order of importance. By that what I mean, certain parts of this history won't be of any importance at all. Then you should just present it in one sentence. So not only presented in the order of importance, they should be emphasized also in the order of importance for the diagnosis and management. Now, when it comes to a obstetric history, A, B, and C, that is introduction, reason for admission or the presenting complaint, dating of the pregnancy, and the menstrual history should be presented at the beginning of the history in the given order. You can't change that order. Although the present obstetric history is usually presented next, components D to I can be presented in the order of importance. So that is where one point where your framework is going to change. Right? A, B, and C are essential. Usually, D is the next point. D is the next one. D and E go in combination, which I'll explain later. So usually A, B, C, and D go in that order. But even present obstetric history doesn't have to come next. Some other history can come next if that is more important. But A, B, and C should be in that order. So examples are history of now, right. I told you just, I'll explain about the history of presenting complaint. History of presenting complaint is usually incorporated into the relevant place in the present obstetric history. I will explain that. Now, say that this woman has diabetes, right? And she has come for the blood sugar series. So that is a present, that is a reason for admission, not a presenting complaint, right? But then you don't talk about that at the beginning. You say, right, this woman has got admitted for doing a blood sugar series because she has gestational diabetes mellitus. But you don't talk about diabetes mellitus at this moment because now that diabetes mellitus would have been diagnosed in the second trimester. Or she may have been a diabetic right from the beginning. I'll come to that later. So her diabetes mellitus would have been diagnosed in the second trimester. So you start with the first trimester. You talk about the events in the first trimester. They're probably it's not complicated. Then you come in the second trimester and you say, right, OGTT was done. And she was diagnosed with gestational diabetes mellitus. From there onwards, you have to tell everything that happened to the diabetes mellitus in the present obstetric history. That is what happened in the second trimester, what happened in the third trimester. So what was the, what sort of monitoring was done, what sort of treatment was given, what sort of complications occurred. So it is given trimester by trimester. You don't give a separate history of the GDM. Same for pregnancy-induced hypertension. In the first trimester, there may be no hypertension. Then the hypertension develops after 20 weeks. So you say come up to 20 weeks, everything is normal. Then you say when she attended the clinic at 24 weeks, she was found to have blood pressure of 140/90. Then from there onwards, in the present obstetric history, you have to describe in detail what happened to that pregnancy-induced hypertension right up to today. I hope you all understood. Otherwise, since we are on the Zoom, you all wanted to be on the Zoom and we are on the Zoom, you can ask me any questions. Don't be scared. I can't see you, and I'm not that experienced as to somehow see your face. So only your voice will be heard. So you can ask me any questions. Right. So that is the first thing. To then what about this? If there's a short presenting history, like antepartum hemorrhage, deep dribbling, or reduced fetal movements, right? She has got admitted because she has a presenting complaint. Right now, the diabetic woman gets admitted for blood sugar series, she has no presenting complaint. But another woman gets admitted because she has developed bleeding, dribbling, or reduced fetal movements, or something of the sort. yesterday. Then she has a presenting complaint and there's a history of the presenting complaint, but still it may be more advantageous to mention the presenting complaint and talk about the history of the presenting complaint at the end of the present obstetric history. Because you start the present obstetric history the first trimester and proceed along the present obstetric history until you come to the presenting event. And then give the history of the presenting event, because that will become almost the last part of your present obstetric history. That might be, even for more intelligent ones, that may be a better way, a more simple way, rather than giving the history of the presenting complaint first. To give the history of the presenting complaint at the end of the present obstetric history, because if there's a definite presenting complaint, that may be the last events in the present obstetric history. Right, so that is one thing you have to keep in mind. Then the next thing is sometimes there may be a history that is more important than the present obstetric history. Right. Now, if this woman has previously had diabetes mellitus, or if she has previously had hypertension, previously had renal disease, previously had any other serious medical illness, heart disease, then because that illness will have a huge bearing on this present pregnancy. Therefore, you can start with you may start with the past medical history. It would be nicer to start that way. Then, hello. Oh, ඉක්මනට කියන මම ලෙක්චර් එකේ ඉන්නේ. මම ලෙක්චර් එකක් කරනවා. මට ඉක්මනට කියන්න නැත්නම් පැය දෙකකින් පස්සේ කෝල් කරන්න. එහෙනම් දැන් මම ඇඩ්මිට් වෙන සෝසි වුණාද? දැන් මම එන්න. Just give me a few minutes. Just give me a few minutes until I take a call.
Okay, madam.
So if the woman has a past medical history, that will have a significant effect on, hello. May patient clinic, with in labor. ඔහාටට කමන්නේ ඩ්‍රයිවර්ට එන්න කියන්නේ. උන්ටවත් ප්‍රශ්න නැහැ ඩ්‍රයිවර්ට එන්න කියන්නේ. So, yes, so detailed past medical history may be presented first in a woman with a pre-existing medical disease, such as diabetes, hypertension, or heart disease. So, because these diseases may have a bearing on this pregnancy. So, idea is to start, you may start, it's not essential, you can always present it after the present obstetric history, but it will have better flow. It's not essential, keep that in mind. If you feel more comfortable, you can present it after the present obstetric history. But if you start with the past medical history, we say a patient with diabetes, hypertension, renal disease, SLE or anything, and you talk about that disease condition, you talk about the control of that disease condition, talk about the drugs that have been given, have there been any preconceptional care, and then from there you can reach the present obstetric history. You can say, this patient is a known diabetic for the last 2 years. She has been on metformin or she has been on glibenclamide. She did not go for preconceptional care, and she realized she was pregnant when the period was missed, and she attended the antenatal clinic at 8 weeks of gestation. Then you go on to tell what was done for that diabetes until when she came to the antenatal clinic. Or you say this woman who had SLE, she was on these drugs, She went to preconceptional clinic. The certain drugs were omitted. She was her condition was stabilized, and she was allowed to become pregnant, and then she became pregnant, and now she's attending the antenatal clinic like that. So you can start with the past medical history. Then in a woman with anemia, you may even start with a dietary and a social history. You may, but it may be better to give it after talking about the anemia. A detailed past obstetric history may be presented first in a woman who has had a previous cesarean section or a bad obstetric history. If woman has had several miscarriages or several stillbirths or even 2 cesarean sections, it may even 1 cesarean section, you can always start with the past obstetric history, give a detailed past obstetric history, and then come to the present history. So why I told you that is, now history has to be diagnostic, no? So if any previous history, like the past medical history or a social history or a past obstetric history has a bearing on the management of this pregnancy, has a strong bearing on the management of this pregnancy, then better to give it first, because that is also part of the diagnosis of the present condition. Because the history should be diagnostic. We would really like to know how her diabetes was at the time she conceived, like to know how her renal condition was at the time she conceived. So, and also we will like to know what was her previous bad obstetric history, why isn't she having any children? Because now that will again have a bearing on this history. If she has had miscarriages, we might have to put a cervical cerclage. Or if she has had an early stillbirth, say around about 36 weeks, we might have to deliver this baby before that time of the stillbirth. Or if she has had a bad obstetric history due to GDM or PIH, we might like to control all these diseases, be on the lookout for those diseases to prevent that thing happening in this pregnancy. So that is why some other history has a strong bearing on the management of the present pregnancy that may be presented first. That also is part and parcel of early, that history should be diagnostic. Then, of course, always a detailed present obstetric history should be taken. Then the most important thing, now your framework is there. Now I told you how you can, that you might not, it's not essential to follow the order of the framework that I have told you. Now the next thing is, it is not, I can't say it's not necessary to go through all the components of the framework, because you all are students, I can't say that. Because some examiners want you to present the entire history within this framework. But what I can tell you, I'm not going to be your examiner. I mean, there's a 16, 8 or 9 panels is 16 or 18 examiners. If I'm the examiner, I will not go into these useless, some useless components, but certain examiners want you to go through the entire framework. So I can't tell you to forget the framework, but what I have to tell you is to spend minimum of time on the not important components. So a detailed history should be taken. A detailed present obstetric history should always be taken. A detailed any other history like medical history, obstetric history, past obstetric history, medical history, social history, dietary history, drug history, all these things should be taken in detail if they are significant. If they are not significant, they should be presented very, very briefly. Now, past medical history should be brief in a healthy woman. I will tell you what I mean by that. Now, all we ask is, Sinhala, I'm sure all of you will understand Sinhalese. අම්මේ ඔයා මීට කලින් කිසිම ලොකු ස්පිරිතාලයකින් බෙහෙත් ගත්තද? ලොකු ස්පිරිතාලයක ක්ලිනික් එකකට යනවද? විශේෂඥවරයෙක්ගෙන් බෙහෙත් ගන්නවද? නෑ කිව්වොත් past medical history is nil of no. Because if they are significant past medical history, that woman should either be taking treatment from a hospital or that woman should be taking treatment from a private consultant. That's the way to get rid of the past medical history within 1 minute. Then all you say is past medical history not significant. In 1 minute, that will only take you 1 minute to ask. කොහේ ලොකු ස්පිරිතාලයකින් ක්ලිනික් එකකට යනවද ලොකු ස්පිරිතාලයක නැවතිලා හිටියද ලොකු විශේෂඥ වෛද්‍යවරයෙක්ගෙන් බෙහෙත් ගන්න නැත්තම් නෑ. අම්මේ මේ විටමින් වලට අමතරව වෙන කිසිම බෙහෙතක් ගන්නවද නෑ. Drug history is nil of no. Then the past obstetric history, if woman has had normal deliveries, what do you say? Then lamai tungana both all three have been delivered normally. Then you say you don't even have to ask the woman details. You can say she has had 3 normal deliveries, all without any antenatal, intrapartum or postpartum complications. All the children are healthy. And if she remembers the birth weights, you say, if she doesn't remember the birth weights soon, you say she cannot remember the birth weights. But if the woman has had a complicated, if she has had a complicated past obstetric history, it has to be presented in detail the way I told you. We'll be coming to it again. If any abnormality diagnosed during the antenatal, these are extremely important. If any abnormality diagnosed during the antenatal period, such as GDM, heart disease, PIH, malpresentations, twins, etc. Now, these are diagnosed during the antenatal period. Women don't come with GDM, women don't come with PIH, women don't come with malpresentations, women don't come with twins. These all happen after she conceives. Previously, these things are not there, but heart disease, of course, could have been there previously, though undiagnosed. So there are so many problems where it happens during the pregnancy because of the pregnancy. So a detailed history should be taken regarding the diagnosis, management, hospital admissions of any and follow-up. Now what you all are used to telling twins was diagnosed. Again, they have diagnosed twins and told her to go, ඔයාට දෙන්නෙක් ඉන්නවා අම්මේ, ඔයා එළියට යන්න ඊළඟ ලෙඩා එන්න. We don't do like that, no. So if she has twins, we explain that she has twins and then we explain what should be done. Right? Now remember, treatment is not only giving tablets. Treatment is explanation also. So you have to say a GDM was diagnosed from the OGTT, then a blood, she was advised regarding the diet. She was advised to take gentle exercise and she was given metformin or whatever it is. What was done for that GDM in detail, you have to say. You can't just say GDM was diagnosed, you can't say a breech presentation or diagnosis. If a breech presentation diagnosed, there are so many things you have to do. You have to tell her that she needs another scan, she might need external cephalic version, or at least you have to tell her that you have this malpresentation and you will need a seizure. So all this will be told. So you have to tell exactly what was done for that abnormality that was diagnosed during pregnancy. You all are please get rid of that habit of just telling a dangerous condition was diagnosed and not talking about the management. And don't think that giving tablets is the only way of managing, because most of our problems, we don't give tablets. It's just a matter of explanations and changing a way of life. So you have to tell exactly what was done at the time of diagnosis and exactly how the disease condition was followed up from the time of diagnosis till the morning that you are taking the history. In very detailed management of that condition. Remember, that is the crux of your history. The abnormality that was diagnosed and how it was diagnosed and what was done for it until now, including any complications that have happened because of that problem. Any hospital admission should be, discussed in detail, described in detail. But you all say, patient was admitted on this day, discharged on that day. That is, she's admitted to the hospital, just kept in the hospital and thrown out to the road. It's not like that. No, she's admitted, she's investigated, she's treated, she's advised, and then she's discharged from hospital with definite advice regarding follow-up. If she has hypertension, we say check your blood pressure twice a week and come to the clinic weekly or 2 weekly. If she has diabetes, we explain how to take the drugs, how to store the insulin, how to check the blood sugars, when to come to the hospital, all that we say on discharge. So all this should be told. Now, why you all don't have time to have another thing, another very important thing that I want to tell you is why you don't have time to take the important details is because you go behind that framework and talk a hell of a lot about the unimportant details. You have this framework right in your forehead and you start filling up this framework in detail without filling up the important facts in detail. This happens in all the other subjects, not only in gynaecology. Usually I get the chance to do this lecture only once they come to the final year. Because I'm so busy with the final years and the postgraduates, I don't have time to do this type of thing. But because of Corona, now we are little bit reduced workload. That is why I'm having the time. Otherwise, I reject all this until the present final year batch leaves. So I'm so happy that I can. I hope that I will succeed in paving the pathway to passing the final exams with colors, because this is a critical thing. Right now, we'll take each component by component. Right, I'll be discussing each component by component in detail. And also because this is internet, this online lecture, we are not restricted with a time schedule. We can either finish it today or finish it tomorrow or whatever it is, or in the evening or whatever it is. So now I will be discussing component by component in detail. Now, what is the first component? First component is introduction. So introduction is a brief summary of the patient. Now, if I can tell you this way, introduction should contain everything that necessary. Say the consultant, you are the house officer. And if you are introducing this patient to the consultant, you should give all the details that are necessary to manage this patient in about 4 or 5 sentences. That is what is meant by introduction. I would strongly advise you, when you are following the ward rounds in every subject, listen to what the house officer tells the consultant. It will be so valuable to listen to what the house officer tells the consultant. Then that will help you to give a good introduction, or at the end of the history, to give a good summary of the patient. So always from today onwards, whatever subject that you are doing, listen to what the house officer tells the consultant during the ward round. Introduction and the summary both are included in that brief 1 minute or so information the house officer gives to the consultant regarding the patient. Now the introduction should have personal details, name, age, occupation, and address. Now the house officer won't tell the consultant name, occupation, and address because she doesn't have time to do that. But she will, in most cases, she will tell the age. So, but you, as you are presenting in history as a student, you have to say name, age, occupation, and address. Address doesn't mean a detailed address, just she is coming from Peradeniya. Then in obstetric history, duration of marriage is important, right? But sometimes if it's long duration, she might not remember it in detail, but whatever she remembers, you can tell. Then the next is the most important, parity, mode of deliveries, number of living children, any abortions or stillbirth should be mentioned. Now this is extremely important to manage the patient. Right, and you have to keep in mind, I'm repeatedly telling, this should only be a summary. You say, right, she's in her fourth pregnancy with 3 living children, all delivered by normal vaginal delivery. There's no point telling she's in the fourth pregnancy unless if you give brief details of what happened in the previous pregnancy. So all you got to say is she's in her fourth pregnancy with 3 living children, all delivered by normal vaginal delivery. Right? Or she's in a fourth pregnancy with no living children. One first trimester miscarriage, one second trimester miscarriage, and one stillbirth at term. That's the way you tell that. Or she's in a third pregnancy with 2 previous cesarean sections and 2 healthy living children. Now remember, this is not a past obstetric history. It's very difficult to, now what the students say, right? Either they just say she's in a fourth pregnancy without giving any details about the previous pregnancy. Or they say, right, she's in a fourth pregnancy with 3 previous cesarean sections. Then they say indication for the first one is this, indication for the second one is this, and the birth weight of the child is this child is no. That is in the past obstetric history. That is not in the introduction. Just a brief summary in half a sentence as to what her parity is, what happened to the previous children, and what were the modes of delivery. That is all that is there in the introduction. So please don't make that mistake and give a detailed past obstetric history in the introduction. Past obstetric history is there later, right? If you feel that it is very important, you can even present that before the present obstetric history. But this is an introduction. This is only a summary. You can't present a past obstetric history here. Neither, that is one end of the scale. On the other end, you just say she's in a third pregnancy. That doesn't mean anything. So you must strike a mean. You have to say the number of living children and the modes of deliveries, but not any further detail. Then the blood group and the rubella status. Why you have to put the rubella status here is because otherwise you all go and talk about the rubella injection in the first trimester as if it is given in pregnancy. Then also, I think it's better if you get used to mention in the pre-pregnancy BMI also here. Or at least it may be difficult to give the BMI, at least the height and the booking weight. It might be good because in so many cases that is important. Then next is reason for admission or the presenting complaint. In most obstetric patients, there is no presenting complaint. Hello. Yeah, Nilu, in a few minutes because I am at a lecture. Just tell me in a few minutes. So when can you send? Are they there in your office now? So I can't come now. That is the problem. 4 o'clock. 4 o'clock. Is it too long? Then wait. Right. I will try. I'll be finishing this lecture around 11 o'clock. So what about 11:40, 11:30 then? Yeah, 11:30. Send them to the channel center, right? Send them to the, where can I do it? Why today Dr. Daphne is not there, is it? All right. Yeah, I know. So if it's possible to do it there, I will do it there. All right, okay. I'll come at 11:30. Okay. Right. Sorry for that interruption. Now, yes, reason for admission and presenting complaint. In most obstetric patients, there is no presenting complaint. Right? Patient is admitted for the management of complications detected at the antenatal clinic. I told this to you earlier. In such cases, the reason for admission should be mentioned very clearly with any complaints if present. Right, for examples are early admission for a planned cesarean section. Indication for the cesarean section should be mentioned because usually now patient gets admitted for a cesarean section. She knows why she is undergoing a cesarean section. So not only just say that she has got admitted for a cesarean section, it would be nice if you say why a cesarean section is done because she had a past section, or a cesarean section is done because she has a breech presentation, or because she has uncontrolled diabetes. Like that, you should be. It's nice because patient jolly well knows why a section is being done, or it may be that she has got admitted for the management of moderate hypertension or gestational diabetes mellitus. That is the reason for admission. Or some people, they get admitted at 40 weeks for observation and delivery without any major complaints. Now, presenting complaints in obstetric patients seeking admission include what's the commonest presenting complaint is abdominal pain, then dribbling, bleeding, reduced fetal movements, edema, or non-obstetric conditions such as fever. So these are the normal presenting complaints. If they have a presenting complaint or they have no presenting complaint, they have got admitted for a planned section or for the management of hypertension, diabetes, or they have got admitted at 40 weeks for observation and delivery. Then it's like I explained earlier, history of the presenting complaint may be given after the menstrual history or incorporated into the present obstetric history. I think the latter is the best. You incorporate it into the present obstetric history. It won't cause any confusion that way. Your present obstetric history will end with the history of the presenting complaint usually if there is a new presenting complaint, or the presenting problems will be incorporated at the appropriate place in your present obstetric history, the way I told you earlier. Right, then one caution about this abdominal pain. Now, all the patients in the ward, they have abdominal pain, but you should be able to differentiate it between labor pains and non-pain that is not due to labor. Only thing, keep this small clue in your mind. A patient in labor will not be given as your exam case. So for God's sake, when you come to the exam, if they ask, is this pain labor pains, always say no. Even if you don't know anything, at least keep in your mind a patient in labor won't be there in the ward. Right, so now I have finished the introduction and I have finished the reason for admission and the presenting complaint. Then dating of pregnancy and the menstrual history. Now everyone will give the LRMP, ED and POA, but that doesn't mean nothing. That doesn't mean nothing. It's so difficult to get this into the head of the students. Now, we use the Nageli's rule to calculate the date of delivery and the POA. And that the Nageli's rule is accurate only if the woman has 28-day cycles with ovulation occurring on the 14th day. Otherwise, Nageli's rule is not accurate. So you're just telling that LRMP, ED and POA doesn't mean nothing. First of all, what are the factors that are there to make sure that the date given by the patient is correct? One thing is she has to remember the date accurately. So to ask the woman, do you remember the date? Do you remember the date? Has the date, have you written it down in the calendar or are you telling it by recall? But can you remember the date? Then also for it to be accurate, she should be having 28-day regular periods. So to mention that she has 28-day regular periods. Then next is, there should be nothing that affects the day of ovulation. අනේ මිස්ටර් බර්ට්‍රම් මම ලෙක්චර් එක ඉන්නේ මට තව වන්දනා පවර්ස් වලින් ඔගේ කෝල් කරන්නකෝ. හරි. Then the other thing is there are other factors that can affect the day of ovulation, like if she's on hormonal contraceptives, if she's lactating, the date of ovulation can be get altered. So it's very important not only to tell the RMP to say, right, her last regular menstrual period is this date. She can remember it very well because she has documented it in the calendar, or she can remember it very well by recall, or she's not sure of the date. Then also you have to say she's in 28-day regular cycle. She's not on hormonal contraception. She's not lactating. Therefore, expected date of delivery is this. And therefore, this is a POA. That alone is not enough. We have to say these dates have been confirmed by ultrasound scan. And to confirm the dates, ultrasound scan has to be done between 10 and 24 weeks. So we have to say these dates were confirmed by ultrasound scan done at 12 weeks, done at 14 weeks, like that. We tell when that ultrasound scan was done. So repeating again, you say LRMPs on this date. She can remember it because she has recorded it in a calendar, or she remembers it by recall. Her periods are regular. She has 28-day regular periods. She is not lactating. She is not on any hormonal contraceptives. Therefore, expected date is this, and POA is this, and this has been confirmed by ultrasound scan done at 16 weeks. So that is how it goes. That is how your dating becomes complete. To get full marks for dating, you have to say all this, because otherwise your Negalese rule is not accurate. And also there's no other menstrual history. Keep it in mind. Don't go on asking all the menstrual the date of menarche. What is that? There's no importance, no. But because she has attained menarche, otherwise she won't become pregnant, no. So there's no point inquiring the date of menarche. Then you ask about dysmenorrhea. There's no point inquiring that now she's pregnant. Now she doesn't have dysmenorrhea. Then you inquire about the flow. Is it of importance? No, she's now pregnant. Whether the flow is less or more, it doesn't matter. Only thing is if she's anemic, then you might have to inquire about heavy menstrual bleeding. Other than that, all you got to ask in the menstrual history is, have you got regular 28-day cycles? Can you remember the date properly? And are you on hormonal contraceptives, and are you lactating? So this covers your menstrual history. There's no other menstrual history. Don't waste time asking about date of menarche, dysmenorrhea, heavy menstrual bleeding, and all that. Those are not important. Then come into the present obstetric history. Then describe the events of each trimester in a chronological pattern. You start with the first trimester. If the woman has attended the preconception clinic or has received preconception advice, you commence at that point. Otherwise, we commence after the woman misses her period. So we have to start now. So we say the woman realized that she was pregnant, or you can start like this was a planned pregnancy. She was on preconception of folic acid, but she didn't attend the preconception clinic. If she has attended the preconception clinic, you give the details at this time. She's on preconception folic acid, which she received from the preconception clinic, and there were no abnormalities were detected at the preconception clinic. This is a planned pregnancy, and she realized that she was pregnant when she missed the period, and she confirmed with a home pregnancy test. This is the normal chronological pattern of a pregnancy being diagnosed. Then usually she might, nowadays they attend the antenatal clinic very early. At least they attend the private sector as soon as they miss the period. So you can mention about the booking visit, right? If it happens earlier, sometimes it happens anyway. In the first trimester nowadays, they have booked. So you have to mention the described events of the booking visit including the results of the first ultrasound scan and other investigation. Another thing is, whenever I mention that an investigation has been done, try to find out the results, at least whether the results are normal or abnormal. And this brings me to another point which I should have told earlier. Now, you can't take the history in the way that laborer will also take the history. History, one thing is, now laborer will also say, "Ameage lay balala thiyena." Lay baluවට වැඩක් නැහැ, and you have to know the results. So you have to say, right, that the booking investigations were done, and at least you have to be able to say all were normal. That woman will know whether those were normal or not. She may not know the values, but she will know whether it was normal. If there's an abnormality, she will be informed and she will be treated. In any subject, whenever an investigation is done, the result should be mentioned, otherwise you fall into the category of the laborer. And also, now don't narrate. That's the other important thing, which I should have told you at the beginning, I forgot. Don't just narrate what she's telling. Always try to go beyond the narration. Try to get more details of the important facts. Of course, not on the non-important facts, but on the important facts. Try to get more details. A narrated history will get very less marks, whereas a more if you analyze critically your history, when you are taking the history, if it's a critically analyzed history, you will get more marks. So get used not to narrate in any subject. So describe the events of the booking visit. Then if there are any complications, now what are the complications you get in the, I'm not going into a lot of technical details because you all don't know much about obstetrics, but I'm trying to be very simple about the technical details. All right, we'll be doing this lecture again. This will be the first class when you come to do the obstetric professorial appointment. That will also be done by me, the first class. So then we'll go into more technical details. Now I'm not going into technical details. I'm trying to be as simple as possible, right? So we start with the preconception visit, and then we talk about whether it was a planned pregnancy. She misses the period. She diagnosed by a home pregnancy test. Then she books in. Then you have to tell about the results of the first ultrasound scan, results of the investigations which were done, and then talk about the events of the first trimester, complications which occur in the first trimester, bleeding, hyperemesis. These are the complications. If there are any complications, you have to describe the diagnosis and management in detail. That is what I mean by it's not a narration. You can't just say she had bleeding. You have to say what was done for that bleeding, what was the diagnosis, and what was the follow-up. So all that is important. She knows. You have to get it from the patient. Now, what are the things which are diagnosed in the first trimester? Briefly speaking, twins are diagnosed in the first ultrasound scan. Heart disease is usually diagnosed at the first antenatal visit. These are the ones that are diagnosed. And threatened abortion can occur in the first trimester. Hyperemesis can occur in the first trimester. So you have to describe about the initial management of all the conditions that have been diagnosed or the complications that occur. Describe the initial management, diagnosis, advice given to the patient, and the follow-up in detail. That is these are the important things. So these are the things, any abnormality is important. So you have to spend a lot of time on that and spend least time on the non-important aspects. Then come into the second trimester. Describe the antenatal care. In the second trimester, they are usually referred to a specialized clinic if they have so far not been to a specialized clinic. Then the findings of the ultrasound scan at 20 weeks. Then OGTT is usually done in the second trimester. I mentioned the results of the OGTT. Then the complication that can occur is bleeding. Then all the results of the first trimester investigations come in the second trimester. So their anemia may be diagnosed, GDM may be diagnosed. If anything is diagnosed, you have to say what was done for it. what were the investigations were done, what was the treatment, was she admitted to hospital, what was the follow-up. All that you have to tell. So, if anything is diagnosed, you have described the diagnosis and the management in detail. Management includes not only treatment with drugs, but also the advice given to the woman. Hospital admission should be described in detail with all details of the diagnosis, inward management, and follow-up treatment. Remember, this is not only for obstetrics, this is for every specialty as well. Then third trimester, describe the findings of the third trimester ultrasound scan and we question regarding complications which could occur in the third trimester, such as pregnancy-induced hypertension, intrauterine growth restriction, antepartum hemorrhage, and malpresentations. And you have to describe in detail what was done for you, how this was diagnosed, what investigations were done, what treatment was given, and what is the follow-up, and also how well are these conditions controlled. The last but the not least last but not the least important thing is how well these conditions have been controlled. In the history, with the history of the presenting complaint, if it has not been stated at the beginning, the present condition of the mother and the baby should be mentioned. Right, so in your history, like I told you earlier, with the history of the presenting complaint, if it has not been stated at the beginning, now I told you rather than giving a history of the presenting complaint at the beginning, even for the brighter students, it is better to give it then you can nicely incorporate it into your present obstetric history. The present condition of the now your history ends with the present condition of the mother and the baby. That is where your history ends. Now, I told you it should not be a narration, so certain negative information, omissions are also important. Also, it is important to briefly counsel the woman while taking the history. This will help you to score extra marks. Narrating what she says is only going to be a very, what shall I say, a very history that will just get you the bare marks. If you want to go higher up, it should not be only a narration, negative information, omissions, counseling, all that is important. So I'll give you a few examples. If the woman with anemia, diabetes, or twins has not been given dietary advice at the antenatal clinic, it should be mentioned, and the patient should be given appropriate advice. So say twins has not been advised regarding the diet. Just say 1 minute, right? Someone is doing it. Right, so whatever has not been there done, you have to mention things which should have been done but have not been done. So then if a woman with heart disease has not been advised to rest and to avoid exposure to respiratory tract infections, it should be mentioned and appropriate advice given. These are only a few examples of what should be done but which have not been done. These things are, if there's anything that has been missed, Now, as you learn the subject, you will realize what are the things that are important in each disease condition. And if those things have not been done, you have to say, right, these were not done. In other words, what are you telling the examiner that I know all this? So if I was the house officer, I would have done this. So that is what I meant when I said you shouldn't narrate. You should go beyond the narration. The woman with a twin pregnancy should be given advice regarding diet, rest, and preparation to receive two babies at the time of diagnosis. If this has not been done at the antenatal clinic, it should be mentioned and suitable advice should be given. You know, if a woman with hypertension has not been given advice regarding the need to check the blood pressure at least once in 2 days, it should be mentioned and appropriate advice should be given. If a woman with diabetes, hypertension, heart disease, twins, or a multipara has not been given appropriate family planning advice, you have to advise the woman. Actually, it's appropriate to end your history with the family planning advice in all to all women. So this is what what I mean by that is what I meant by uh, briefly that history should not be a narration. History should be beyond a narration. If we have to talk about omissions, commissions, all the important things. But that doesn't mean that you should be very brief regarding unimportant things. Why you all now see, now if you take a doctor, a practicing doctor, a doctor takes a very short time to take a history. Why? Doctor knows what are the important things to ask. Now, at the channel center, we finish in 5 minutes, but we don't miss anything, no. Now, you always say we are consultants, right? But at your level, also, if you have 20 minutes, that's a huge amount of time to take a history. Now, if you start spending 20 minutes to take a history when you become a doctor, you won't be able to finish your day's work. So you should be able to target your history. That is the most important. Target at the important things and not ask a word of, not spend. Now you all have a framework, no, so you have to stick to that. But just spend 2 minutes on that framework if it's not important. Now coming to the other details. Past obstetric history. If a woman has had uncomplicated normal deliveries, mention briefly the number of deliveries, the birth weights, and the health of the children. Health can mean that she has living children, healthy living children. You don't even have to ask this. Now when you go to that woman will say, right, I am in a third pregnancy. Then you ask what happened to the previous children. She will say, I have 2 children and we all delivered normally. එතකොට ආයෙත් past obstetric history එක අහන්න නැතුව නිකම්ම කිය, don't spend time even asking. You say she has 2 living children. She has had 2 pregnancies. She ended in normal deliveries. No antenatal, intrapartum, or postpartum complication. All the children are alive and healthy. Birth weights, if she can remember. So we have spent 2 minutes in giving this history. We have not spent any time in asking this history again. But if the past obstetric is significant, it can even be presented before the present obstetric history. A detailed description should be given if the woman has had previous obstetric problems, as the management of the present pregnancy may depend on the outcome of the previous pregnancies. If the woman has had a previous cesarean section, the indication, type of uterine incision, intraoperative and postoperative complications, and the health of the previous children should be described in detail. You have to give the indication in detail that we will teach. You know, you can't just say prolonged, like we have to say whether for how long she was in the labor room, was she on oxytocin infusion, like that. You can't loosely say it was done for prolonged labor. Then whether it was a lower segment cesarean section or upper segment cesarean section, did she have any post-operative complications? Is the child live and healthy? All that you have to give. If the woman has had a previous stillbirth, all the details regarding the previous stillbirth should be mentioned, which you will learn later. One previous abortion is not significant. Recurrent abortions require careful inquiry. All these, just keep these things in mind. You will learn these things later. So you might learn in the next appointment, you have to take very detailed histories if these things happen. Otherwise, you just briefly do away with it, spending less than 1 minute. Past medical, surgical, and drug history, I told you how to do away with it in few minutes. If she has any illness, it has to be described in detail. A diagnosis, the present condition, drug therapy in detail. Drugs may have to be modified during the pregnancy. All these should be mentioned, and she should be referred to the appropriate clinic to describe in detail if the woman has a previous medical condition, because that is the crux of your history. That is, you get marks for that. So significant medical history to describe in detail. No significant history, 1 minute and it's over. Social history should be very brief. අනේ ඔයගොල්ලෝ අහනවා ගෙදර කී දෙනෙක් ඉන්නවද ඉස්පිරිතාලට කොච්චරක් දුරයිද? We don't care whether she has a vehicle. Those are not important, no, unless the woman has a placenta previa. These things are not important because in Sri Lanka there's no system where ambulance goes and from the hospital will go to bring a patient. Of course, there's ambulance service now, but that is not our business now. We don't arrange for ambulance transport. So we don't need to know how far she is from hospital, whether she has transport. All that is not how many people are there in the house. Does she have, how many toilets she has? No. We give a brief social history. The education and the occupation may be mentioned. A more detailed social history is required in teenage pregnancies, grand multiparity, and anemia complicating pregnancy. Then, of course, you have to give a more detailed history. Other than that, in all the others, you just give a very, very brief history. Just 2 sentences and 1 minute. ඔයා කීයට ඉගෙනගෙන තියෙනවද මහත්තයා කීයට ඉගෙනගෙන තියෙනවද ආරස්සාවක් කරන මහත්තයා රස්සාවක් කරනවද එච්චරයි. ඉන් එහාට මුකුත් ඕනේ bloody waste of time. Right? Unless if the social history has a bearing on a present condition like a teenage pregnancy, grand multiparity or anemia. Then a dietary history should be as brief as possible in a well-nourished woman with a normal BMI. You just say, you don't even have to ask. When you look at the patient, if she appears normal, you don't even have to ask. You can just say, your diet is adequate in proteins, calories, and vitamins. You don't have to spend time asking. Right? Usually, if I'm face-to-face, I show the girls and say in the batch, if these girls become pregnant, you don't have to ask about dietary history because they are all well-nourished people. So detailed dietary history is of course needed with a 24-hour record in anemic patients, diabetic patients, and where there's a high or low BMI. So this is a lot. I hope you all understood. I'll give you 2 minutes to ask any questions if you all have any questions. Pavita, is it clear? Any questions? Any questions? නැද්ද? මොකුත්ම තේරුම් නැද්ද? Because it's very, very important. I have given about 2 minutes for people to ask questions. Okay.
Excuse me, madam.
Go ahead, you also can ask.
Excuse me, madam.
Yeah.
If there are 2 diagnoses and both are like known, then how should we present?
Yeah,
it?
then you say she's a known patient with pregnancy-induced hypertension and diabetes mellitus. Or she has got admitted for investigation of twins complicated by diabetes mellitus. Like that. Did I answer your question?
So it should be at the beginning of the history.
Yeah, beginning of the history, because that is what she gets admitted for. I mean, most cases, it should be at the beginning of the history. Now, she has got admitted for diabetes for the management of twins complicated by diabetes mellitus, right? Or she has got admitted, I mean, she's a primary gravid, that is not a problem, who has got admitted for the management of heart disease complicating pregnancy. Because she tells it at the beginning. When you ask, why did you come to hospital? She will say, I have twins, and also on top of that, I have diabetes. So that is what she has told you, and that ultimately becomes a diagnosis. Did you understand that?
Yes, madam.
And
Thank
if,
you, madam.
I'll tell if it's in a medical case, she will say, මට මේ heart attack හැදිලා තමයි මම ආවේ. So she has come for the management of ischemic heart disease. You can't say she came for the management of myocardial infarction without a definite history as far as I know. You can say she came for the management of ischemic heart disease. She will say, මට දිය වැඩියාවක් තියෙනවා, මට heart attack හැදුණා. Then you say she is a known patient with diabetes who came for the management also and ischemic heart disease. Like that in most of the clinical specialties, they will say, or this woman has come, this woman or man has come for herniatomy, he also has diabetes mellitus. So he has got admitted early to control diabetes mellitus before herniatomy. Did you understand?
Yes, madam. Thank you, madam.
Any other questions? Right, now going on to the examination. It's a little difficult to do it like that, but I try to explain as much as possible. And we will, the moment these things settle, even in afternoon, I will take you group by group even and do the examination. At least I'll get the registrars to do it even when you are free. That we'll arrange later. Right, usually what I do is I do this lecture and then do the examination in the ward. Right, because usually I do it in the final year, no? Right, so obstetric examination has the following components, like any other examination. General examination is always there. Examination of breast is always there in a woman, whatever she comes on. Then examination of the other systems, that is always there. Cardiovascular and respiratory system. Then abdominal exam. So I'll take one by one. Now, when it comes to general exam, all you got to remember is a healthy young woman. So general examination, very few things have to be noted. Whether she's height and the weight, height and the present weight, right? Height and the weight, and whether she's pale. Conjunctiva and the tongue. Is she pale? Then about is the thyroid enlarged? Are there any dental caries? You don't have to look for things like cyanosis, icterus, because these are healthy people. You can look for cyanosis if she has heart disease, that I'll come to it later. But in a general obstetric examination, height, weight, pallor, thyroid enlargement, dental caries, ankle edema, and varicose veins. That's all. This lymphadenopathy, finger clubbing, nothing is necessary because these are healthy people. It's a disadvantage to go into those details. Then breast, why do you examine the breast? Only for just two reasons. Don't tell any other mad things. You examine the breast for lumps and to see whether breasts are suitable for breastfeeding. It's certainly not for signs of pregnancy. Because she is pregnant, there's no need for further signs of pregnancy. Then the cardiovascular and respiratory system, they are healthy people. Be as brief as possible. Spend 1 minute on it. Just check whether there are murmurs in the heart. And while you are checking for murmurs in the heart, just check whether the respiratory system is normal. Spend 1 minute. Unless the woman has a cardiovascular or a respiratory abnormality, then she would have told you at the beginning. Then that is a problem. That is the main problem. She has heart disease complicating pregnancy, or she has a respiratory disease complicating pregnancy, which is of course very rare. Then you have to do a detailed examination of the cardiovascular respiratory system according to the way you are taught in the medical world. Other than that, just for God's sake, spend only 1 minute. Then CNS examination is not necessary unless it's a definite CNS problem. Now, this general examination and the other systems should be done before you come to the before you come to the before you come to the examiner. Now again, general, reading through what is there in the note, general examination should include examination of palo, ankle or sacral edema, thyroid enlargement, varicose veins and dental caries. Right, that there. A more detailed examination not routinely carried out as a pregnant woman is usually healthy young woman. Examination of the breast only to confirm that nipples are everted and suitable for breastfeeding and to exclude masses. Examination of cardiovascular system. It's very important to measure the blood pressure properly. It should be measured in the seated or left lateral position to avoid the effects of cable compression by the gravid uterus. In a woman with an obvious cardiovascular disease, routine auscultation of the heart is carried out for murmurs. Without an obvious cardiovascular disease, you just carry out routine auscultation to exclude murmurs. Just take few minutes, 1 minute to do it. But a thorough and methodical examination should be done if a cardiac disease is present. I'm repeatedly telling you, you don't get any marks for doing this cardiovascular examination. If there's no cardiovascular problem, so be as brief as possible. Don't waste time on things for which you don't get any marks. You may not even be asked for the results. Respiratory system also be very brief. Right now, you should do all these examinations before coming to the examiner. If you say, I haven't done the general examination and examination of other systems, you will lose marks of that. You have no time to be doing it in the presence of the examiner. You should do it and come. So your 20 minutes is not only for taking the history, but for doing the general examination as well. So when you are taking the unimportant parts of the history, always do the examination and finish it, because your general examination will generally be normal. So it's not an important part of your marking system. And also another thing, another word of caution is always write down the history. Because even those who are good in English, if you don't write down, in your excitation you will miss. So always write down the important parts of the history. But when you come to the unimportant parts, like past medical history, past obstetric history, and if these things are not important, while you are asking that, you can start the examination as well. Right, so that is the way to save time, but always write down the history in detail, because you will forget. Even those who are good in English, you will forget. And also, those who are good in English can have some, it's good to have eye contact with the examiner, but eye contact is not essential to score marks. Try to have some degree of eye contact, but since you're undergraduates, the most important thing is to give a detailed, good history without unwanted details. The wanted details should be there, but don't have unwanted details. Then obstetric history, I hope I can simulate with words. Now, it has 3 components like any other examination: inspection, palpation, and auscultation. Right now, you are standing on the right side of the patient, right? You have to, first of all, make an because I'm not with the patient. First of all, you have to get consent from the patient to do the obstetric examination. Obstetric examination, getting consent is not a problem. I will later on tell you how to get consent for the gynaecological examination. Obstetric examination, getting consent is not a problem. Gynaecological examination, of course, getting consent is a little bit of problem, which I will tell you how to circumvent that problem. So you are standing on the right of the patient, get consent, and you have to expose the patient well, screen the patient, but expose her well. Now you have to get her to lift the buttocks and get the clothes down from behind, because otherwise the clothes, if you just bring down the clothes only from the front, clothes will always pop up and make your examination difficult. So ask the patient lift the buttocks and take the clothes down from behind as well, not only from front. Right now you are well exposed. So you are standing on the right of the patient. You can just imagine this, go into those diagrams, right? I'll come to that in a minute. First is inspection. So usually what you make during inspection is nothing much. Look for pigmentation, surgical scars, distended veins, and visible fetal movements. Now don't go to the, I don't know from where you have got this information. Don't go to the bottom of the bed to make the inspection. Have you ever seen a doctor inspecting from the bottom of the bed? No. So inspection is also done from the right side. Another thing now again I have to tell you is, you have to talk like a doctor, you have to act like a doctor, you have to do everything like a doctor. Then only you can score distinction. Because when we were students, when we went for the final exam, we were called doctor. But now we have got so friendly with you all, and we are so used to calling people by their names, we don't call you all doctor. So, because now no one is for that matter called doctor, everyone is called by the first name. Otherwise, actually, you all are doctors by the time you go for the final exam. So, you have to talk like a doctor, act like a doctor, and do everything like a doctor. That is why I started at the beginning saying history should be scientific. So, what you do also should be scientific. You can't go to the bottom of the bed and inspect. That's not professional. So, do the inspection also from the side of the bed. So these are the things you inspect for, not very important in obstetrics. Then the palpation. Now we'll imagine that we are by the side of the patient. Now actually the 4 Leopold maneuvers are the most important ways to examine. Please don't go through the internet for examination, because I'm yet to come across a proper examination technique in the internet. Now just because you are not by the side of the patient, don't go into the internet to get the examination. Right, so stand on the right side of the patient. First maneuver is to palpate the height of the fundus. So you do it with the ulnar border of the hand. You come from the siphisternum to the upper border of the fundus. Now, remember you have to all, it's in the midline. You assume that the fundus is in the midline. Some people are in the habit of going into the right hypochondrium, left hypochondrium. Don't do that, because that will only confuse matters. Come in the midline to the highest point of the uterus, which is the fundus, and measure in centimeters from the fundus to the siphisternum. And that is called the symphysis fundal height. Always use the ulnar border. There are certain small things there which we will teach you when you come for the appointment. There are some shortcuts, but for the present, come. Now you are just facing across the patient. You are just facing across the patient. You are standing on the right side. Actually, you are facing the tummy. And you come from with the ulnar border of the hand from the siphisternum right up to the highest point of the uterus in the midline, which is the fundus. And then you palpate for the symphysis pubis, and you measure the symphysis fundal height in centimeters. And you cannot say symphysis fundal height corresponds to 32 centimeters, but you have to say whether it corresponds to the period of amenorrhea or not. It's always plus or minus 2 centimeters. So that's the first thing. Next maneuver is to feel for the head. So you turn and face the feet of the patient, and with your two using both hands, the way it's shown in the diagram, facing the feet of the patient, you palpate the lower pole. There are better methods than this, which are not very authentic. You will be taught it when you come for the professorial appointment. So at the moment, we'll stick to the Leopold technique. So Leopold maneuver is to turn facing the patient's feet and palpate the lower pole using both hands. Then you say, right, there's a hard palatable mass in the lower pole, which is the fetal head. Therefore, the fetus is in cephalic present, and this is the way to present. Now, because we expect a running commentary, so you say, symphysis of light is so much, therefore, so much it corresponds to the period of amenorrhea. I can palpate a hard palatable mass in the lower pole, which is the fetal head. Fetus is in the cephalic presentation. There is one more maneuver which is not there in the Leopold maneuvers. Then we keep our 5 fingers above the symphysis pubis and see how many fifths of the head is palpable above the pelvic brim. So we say now, if all 5 fifths are palpable, it is always divided into fifths. That is why we place the fingers above the symphysis pubis. So we say 5 fifths of the head is palpable above the pelvic brim. Therefore, the head is not engaged. Or only 2 fifths only 2 finger pits or 2 fifths can be palpated above the pelvic brim. Therefore, the head is engaged. These things are technical details which we taught later, but you must know that other than this, once we have palpated what is there in the lower pole, we have to say whether the presenting part is engaged or not. So for that, you place the 5 fingers just above the symphysis pubis and say how many fifths of the head is palpable above the pelvic brim. In the lecture hall, I used to show this with a model. But anyway, I'll think of something for this. Then you have to turn again and face the patient. Face the patient's face. And then using both hands, you palpate the upper pole. So now the head is in the lower pole, you say, right, there's a firm, it's firm, there's nothing boggy in the uterus. Children say boggy mass, no. It's a firm, irregular mass in the upper pole, which is the breech. Now, if you have felt a head in the lower pole, be very smart, go directly to the upper pole and say, right, there's a firm, irregular mass in the upper pole, which is the breech. Now, the next sentence to say is, therefore, it's a single fetus in the longitudinal line. Why is it a single fetus? Because there's only one head and one breech. In other words, there are only 2 fetal poles, therefore it's a single fetus. Why is it in the longitudinal line? Head is in the lower pole and breech is in the upper pole. And the lie is completely vertical or longitudinal. And then next, facing the patient, you palpate the 2 sides and you say there's a firm curved structure in the right side or the left side. There and the limb, and I can feel irregular masses in the right side. So therefore, the fetus is in the left occipital anterior position. So the side of the back is the one that is taken as for the position. The back is on the left side is left occipital anterior, left occipital lateral. If the back is on the right side, it becomes right occipital anterior, right occipital lateral position. Now, these are basic words. If you miss on these words, මොකද්ද කියන්නේ බෝලයක්වත් දන්නේ නැහැ. මෙයා කවදාකවත් ප්‍රසන්ට් කරලා නැහැ. ඒක තමයි කියන්නේ. You can't afford, it's not occipital anterior presentation. It's left occipital or right occipital anterior lateral position. Then there are 2 other maneuvers, which I will explain to you once we can see you face to face. But if you know these 4 maneuvers, it's more than enough. But is it height of fundus? You face, I hope you all can see me. You face the patient, just stand. Now, if the patient is on the right side, it's like this, you are standing on the right of the patient, you just face transversely. height of fundus is so much, measure. Symphysis fundal height is so many, 32 centimeters, corresponds a period of amenorrhea. Turn and face the patient's feet. Head is in the, I can feel a hard palatable mass in the lower pole. Therefore, the fetus is in cephalic presentation. Keep your forefingers and say, right fingers and say, I can feel 2/5 of the head above the pelvic rim. Therefore, the head is not engaged. Turn and face the patient's face and say very firmly, I can feel a firm irregular mass in the upper pole, which is a breech. Therefore, it's a single fetus in the longitudinal line. In the same position, you palpate the right and the left sides and say, I can feel a firm regular mass in the left side, which is the fetal back, and knobby masses in the right side. Therefore, the fetus is in the left occipital anterior position. So there's a little more like fetal weight and the LICO content, which you can learn later. So we'll just read through this, right? The bladder should always be empty. That's one thing I forgot. Before obstetrics or gynecological examination, bladder should be empty. So here I haven't mentioned about the getting the consent, so that is necessary. Obstetrician stands on the right side of the bed facing the abdomen. Abdomen should be exposed from the syphisternum to below the symphysis pubis, which I told you. 4 maneuvers are carried out during the basic obstetric examination as shown above. Palpation of the uterine fundus is the first step in the an obstetric examination. Aldam order, the left hand is moved down gently from the syphisternum till the fundus is felt. Symphysis fundal height is measured in centimeters from the fundus to the symphysis pubis. The POA is related to the symphysis fundal height plus or minus 2. Next, the obstetrician turns to face the feet of the woman. Lower pole is palpated using both hands as shown in the second picture. 5 fingers of the left hand are placed over the head to determine the part in fifth, which is palpable above the pelvic brim. The presentation and the level of engagement of the presenting part are mentioned at this stage. Next, the obstetrician turns to directly face the woman. Upper pole is palpated using fingers and palms of both hands as shown in the third picture. The lie of the fetus can be mentioned at this stage as the position of the head and the breech are known. If one fetal pole is in the lower part of the uterus and the other is in the fundus, lie is longitudinal. If one pole is in the iliac fossa and the other is in the hypochondrium, the lie is oblique. That is why I told you always go to the upper part of the midline, upper pole in the midline, not go to the hypochondrium, because then you will confuse with oblique lie. Because if one pole is in the hypochondrium, then the other has to be in the iliac fossa, and then we call it an oblique lie. It's not a longitudinal lie. We will explain this nicely when we meet it. If one pole is on one side of the uterus at the level of the umbilicus and other is on the other side at the same level, the lie is transverse. If there are only 2 poles, the woman has a single fetus. If 3 or more poles are felt, a multiple pregnancy should be suspected. Facing the same direction on the sides of the uterus, facing the same direction, sides of the uterus are palpated to determine the position of the back and the limbs. In a cephalic presentation, if the back is anterior, fetal position is regarded as occipital anterior. If the back is lateral, fetal position is regarded as occipital lateral. Forget about the occipital posterior for the moment. Forget about the LICO content and the fetal weight. Now we have to auscultate over the back of the fetus. Right now, if you are not very sure where the back is, you can always auscultate and confirm as to where the back is. Now, I will give you one good word of advice. always do the abdominal examination and get your findings correct before coming to the examiner. Why? Because then you know exactly what is there, and you can really present with confidence without just spending a lot of time, right? And also, I told you there are certain shortcuts which I will explain when you come for the appointment. Keep this firmly in mind. Now, you can't do these shortcuts in front of the examiner. So, you can use all those shortcuts before coming to the examiner. Then, the third and the most important thing is patient knows the diagnosis. Patient knows that now you are not sure whether there is a head or a breach in the lower pole. If we are not sure, always ask the patient, ඔයාට මේ අන්තිම ස්කෑන් එකේ බබා හරහට ඉන්නවා කියලා එහෙම කිව්වද? නෑ කියලා කිව්වොත් ඔයාගේ බබා ඔළුවෙන්ද ඉන්නවා කිව්වේ. If she says no, it's a head presentation, then you have made the mistake, you can palpate again. If she says නෑ නෑ හරහට ඉන්නවා කිව්වා මේ ඊයේ ස්කෑන් එකක් කරා මෙච්චර කල් කිව්වේ ඔළුවෙන් ඉන්නවා කියලා ඊයේ ස්කෑන් එක කළා හරහට ඉන්නවා කිව්වා. Then you know that you are correct, that it's a breech presentation. Then if you feel the symphysis spondylitis larger or smaller than the POA, then what you can do is you can always ask the patient, ඔයාගේ මේ බබා පොඩි කියලා කිව්වද? ඊයේ ස්කෑන් එකේ නැත්තම් ලොකුයි කියලා කිව්වද? If the patient says no, they said my baby is of normal weight, then you can measure the symphysis spondylitis again and correct yourself. So because of these things, always do that. Keep a little time. Do a brief abdominal examination and get the findings before coming to the examiner. ඔවා කිව්වට ළමයි කරන්නේ. ඔවා කරන ළමයින්ට තමයි distinctions හම්බ වෙන්නේ. ඔවා කරන්නේ. Now I'm not going into the gynae examination now. I will do it later, but I want to tell you a few more things. Right, just give me a minute. Now, when you go for the exam, you have to always get the better of the examiner, right? That is the most. I'll just speak a few words about the exam before winding up. I'm a little tired now after talking, that's why I don't want to do the gynae now. I will fix a time with you all to do the gynae. Just give me a minute. I want to tell you a little bit about the exam. Now, the main thing about the exam is there are a few important things about the exam. I will send you that note also later on. Right, one thing you have to remember is, I don't think I'm going to finish this, but I'll do a little. One thing you have to remember is for undergraduate examinations, patients are selected from the ward and from the clinic. Therefore, only patients who are commonly found in the ward will be included. They will be straightforward, uncomplicated patients, usually with a single pathology. Now, what are the common gynae patients you are going to get? We'll first talk about obstetrics. What are the common obstetric patients you are going to get? PIH, diabetes, intrauterine growth restriction, past season, and maybe rhesus incompatibility. These are the patients that are there in the ward. So we have to be thorough with this. Mainly diabetes and pregnancy-induced hypertension and past season. Then, of course, intrauterine growth restriction is also fairly common. They are also fairly common in the world. Then, twins and breech are rare. Twins is commoner than breech. So, if you have to be ready for twins and breech also, few of you all will get. Rhesus incompatibility is fairly common and you might get. ඔය ටික තමයි එන්නේ මොනවා කරා. ඔය ටික තමයි එන්නේ. Rest of the things are rare cases. So we have to be thorough with diabetes, pregnancy-induced hypertension, how to manage a past seizure, how to manage a small for gestational age child, rhesus incompatibility, and twins and breech less commonly. Complicated chronic patients with 2 or more disease conditions, maybe this book is for undergraduates as well as postgraduate. We may be recruited for postgraduate examinations, but not for undergraduate examinations. Patients recruited for undergraduate examinations are instructed to give a clear කිසි දෙයක් හංගන්නේ නැහැ ඔයගොල්ලන්ගෙන්. Patients are instructed not to withhold any information from the candidates. The clinic file, make a මතක තියාගන්න. Clinic file and other details are usually taken away from the patient, but candidates can peruse any available records. Therefore, candidates should always ask the patient for any available records. Ek crime එකක් නෙවෙයි. If the people have forgotten to take away the details, you can always peruse. That is your cleverness. That is your cleverness. You will get plus points for that. The scan is expensive, you know. They nicely fold it and keep it. They don't give the wall because they have spent so much of money to get the scan done. Then undergraduate students should be familiar with the diagnosis and management of common conditions encountered during clinical clerkships, as similar patients will be given for the examination. Therefore, this is very important. Try to see all the involved patients, not only the patients allocated to you, and maintain short summaries regarding the physical signs, diagnosis, investigations, and maintain short summaries. Then it will be very important for you because you have short summaries. These can be very useful for revision. Actually, you should visit other wards during your free time. Main thing is see as many patients as possible, not only the patient allocated to you. If you know all the patients in the ward, if you know all the diagnosis, all the management, then your clinical exam you can get a distinction. ඔයගොල්ලෝ දීලා තියෙන එකේ හිස්ටරි ගන්නෙත් නැහැ බලන්නෙත් නැහැ ෆලෝ අප් කරන්නෙත් නැහැ මොකොත් නැහැ හරක් වගේ තියටර් එකට යනවා ඉච්චරයි තියටර් එකට ගෙනියන්නේ මොකද්ද කියලා දන්නේ නැහැ ඕමනම් පාස් වෙන්න බෑ. Then at the end of each clinical session, read your standard textbooks to obtain more information regarding the management of patients you have seen. This is very important. If there are any discrepancies, clear your doubts by asking a senior staff member. Now, you read a book, right? Book gives us different management. We manage differently. Then you think the book is correct and we are wrong. So keep the book in the mind. And when you come for the clinical exam, you come out with what is there in the book, not with what is being done in the ward. And then you are wrong. Right? You always think what we do in the ward are wrong. What is there in the book is correct, right? Sometimes we may be wrong. So if you feel that we are wrong, we have taken shortcuts, please inquire immediately from a senior staff member, senior doctor, whether we are wrong or whether the book is not compatible with the Sri Lankan setup. That is extremely important. One of the major mistakes that students do, assuming that things are wrong, and giving what you think that is correct at the exam. අයියෝ ඔයගොල්ලෝ හිතන්නේ අර වෙන කොහෙන් හරි ආපු එක්සැමිනර්නේ එතකොට දැන් මේ වාටුවේ කරන්නේ ඔක්කොම වැරදි අර පොතේ තිබිච්ච ඒවා තමයි හරි. එතකොට අර පිටින් ඇවිල්ලා ඉන්න සර්ට හරි එක කිව්වම තමයි අපිට ලකුණු. In the end you completely flop. Because what is there in the book is not compatible with our setup. But I admit that sometimes we are wrong, we take shortcuts. So if ever you feel that in any ward the management is not what should be, but always ask and correct your doubts. You should try to present as many histories as possible during ward teaching sessions, as this mimic the examination scenario and will help you to face the examination with confidence. Have an inquiring mind. Inquiring mind, ask questions from your teachers whenever you have doubts. Train yourself to have an analytical approach and a practical approach to clinical problems. Arrange extra ward classes with the registrars, senior registrars at night and during the weekends. They will always oblige you if you have a problem. And peer group discussion should be held daily, as they are very helpful to learn about each other's patients. You all never discuss the patients with the others. Very useful to practice presenting cases to your peers. I will stop here because I'm tired. So I will talk about rest of this. I will send you a note, this note to you all, because it's very important about how to face the exam. I'll send it to you all, and I will maybe tomorrow I will find a time to talk to you about the gynecological history taking and examination. The discussion is open for questions. It will be open for 2 minutes for questions. You can always send me email. If you come across questions late, you can always call me. My phone is always on and I answer the moment it rings. You would have seen that even during the lecture, I answered my phone. So lecture is open for questioning.
Excuse me, madam.
Yeah, Pavita, yes.
When you're checking for whether the head has been engaged or not, you have to measure above the symphysis pubis the finger breadths.
Yes, with the finger breadths, right? Now, if it's not 10 gauge, I will explain some more. If it's not 10 gauge, all 5/5 will be palpable. So most of the head will be palpable. If it's really not engaged at all, right? And it will be palatable. But little by little, the head will go in. At one stage, you might feel if all 5/5 are palpable, it will be palatable. You can palate it. So once 1/5 goes in, only 4/5 will be palpable, and then it may not be palatable. Then another fifth will go in, only 3/5, only 3 finger breadths. So the head will be felt, only 3 finger breadths of the head will be felt. So when the other fifth goes in, only 2 finger breadths are felt, and then it becomes engaged. But don't worry about this, right? Don't worry about this at all. But try to just practice this when you go for the next next obstetric appointment. Try to palpate and see how many fifths of the head has gone in. Because if you can feel the head with all 5 fingers, that means it's fully out. If you can only feel the head up to about 4 fingers, then still it's not 10 gauge. 3 fingers also is not 10 gauge. Once only 2 parts of the head is palpable above the pelvic limits engages. Don't worry about it, but try it when you go for the next appointment. Try to palpate it. Is it okay, Pavita?
Yes, thank you, ma'am.
And also, if you all are interested, I can arrange with the registrars. Now we have 5 postgraduate trainees with us because we are teaching so well. 5 people have come to us. There are 5 or 6, even I can't remember the number also. So whenever you all are free, only thing these days you all are not supposed to come to the faculty, that is the problem. So when you all are supposed, are you all doing clinical still? Pavita, are you all doing clinical still? Are you all going to the wards?
No, madam.
No.
Yeah, no.
When you start going to the wards, I'll get it organized so you all to be shown these examinations by one of our postgraduate trainees. Keep me informed when you start going to the wards. Before that, it's illegal to take you to the wards, though the final years are there. I don't think I'll be able to take you to the wards. Any other questions? Now I hope this gets recorded, right?
Yes, madam, it is being recorded.
Hello. Hello? Hello, Kiana.
Did you tell them that you're going to?
Yeah, I can end this now.